Okay. Part 3, Section D, psychological aspects associated with exercise prescription. So some initial comments. Most of the content is taken from the ACSM guidelines. Uh, you will get more of this information in the health behavior change course. So this is really just providing you with a little bit of a basic information associated as it relates to exercise prescription. But it's either a review or an introduction to the material, and then you'll get more in a future course. And then focus areas, barriers, goal setting, your role, and enhancing success. So some basic theories that we'll be talking about. The social cognitive theory that's associated with self-efficacy, the trans-theoretical model, stages of change, health belief model, the importance of health, the self-determination theory, which is associated with motivation, and the theory of planned behavior. What are your intentions, and the socio-ecological model, which talks about the environment that you're living in. And by environment, that's also the people that are around you. So this slide shows you the social cognitive theory of self-efficacy. So some of the key components here are mastery of the experience. So how do we get people to be more confident in the activities that they're completing, and how do we work towards those things? And that's especially important as an exercise physiologist. Oftentimes, the personal trainer or exercise physiologist, it seems like their role is more of what I would call an exercise caddy, setting up the weights and doing things like that. And also, if you're doing it more, thinking of it more from an exercise physiology perspective, you're developing the program for the individual. But if you're just developing the program and then the individual implements it and doesn't really learn anything, then are they truly mastering the activity? So that's something that we should be teaching them and guiding them towards, is how to master the activity. How do you do the activities right? How do you develop a basic program for yourself? Vicarious experiences, have other individuals with similar backgrounds perform the task. So essentially watching other individuals complete the exercise. That's helpful. Sometimes you don't notice it on yourself, but you notice it on somebody else, and you can provide each other with feedback. Verbal persuasion, have others tell the individual that he or she can be successful, so to essentially be upbeat and positive. And then physiologic feedback, to communicate the meaning of different signs or symptoms associated with the behavior, the movement pattern. This is how it should feel. If you do this, then see how it feels different. Things like that. Stages of change, trans-theoretical model. You probably have gotten this before. Pre-contemplation, you have no intention to change. Contemplation, you're thinking about changing. Preparation, you're getting ready to change, but you're not quite meeting the recommendations as it relates to exercise. Action is when you're regularly meeting the recommendations, but you're doing that for less than 6 months. And maintenance is meeting, meeting the recommendations and being regularly active for more than 6 months. The health belief model. Perceived susceptibility, beliefs about the change, the chances of getting the disease, the condition if you do not exercise. I mean, you see this a lot with COVID. I mean, this is very pervasive with COVID. What do you think your chances are of getting COVID? And if you get COVID, what is going to be the health effects? I mean, if you think you're going to die from COVID, I think you're going to take a very different approach versus if you think that, I'm just going to get it, I'm going to be okay, it's no big deal, moving on, then the perceptions are going to be very different. And that's also going to be true for chronic disease. And that's part of the problem with chronic disease, the negative health effects are typically further on down the road. So people don't see the need to change immediately because it's probably not going to be a big deal for a while. Perceived severity. beliefs about the seriousness of the condition, perceived benefits, beliefs about the effectiveness of exercise to reduce the susceptibility and the severity of the disease, perceived barriers, belief about the direct and indirect costs associated with exercise, cues to action, factors that activate the change process and get someone to start exercising, and then self-efficacy, confidence in the ability to complete the activity or behavior. So it's your belief on how important all this stuff is, and you'll see that different people put different levels of importance into these various aspects of health and disease prevention. Self-determination theory, levels of motivation. Amotivation would be no motivation. Extrinsic motivation, where others determine it. So that would be incentive programs. You're not doing it because you want to do it. You're doing it because you're going to get some sort of reward. Your health insurance premiums will be less. You'll get a t-shirt, something along those lines. As opposed to extrinsic self-determined motivation, you're looking at the reward for yourself. You're not doing the activity because you necessarily want to. You're doing the activity because you want to reach a certain performance goal. And this level of motivation, there's really absolutely nothing wrong. Well, there's nothing wrong with extrinsic motivation. It's just that it won't last. Once the incentive is over, then you'll probably stop exercising. And once you don't care about the incentive, then you probably won't continue to do it. Whereas extrinsic self-determined motivation, you want to feel better, you want to look better, you like the way you feel after the activity, things like that. And those are very good and fine reasons to exercise. Intrinsic motivation, I do it because I like it. I want to go for a ride, a bicycle ride, because I like riding my bicycle. I want to go for a run because I like to run. I'm going to go to the weight room because I like to lift weights. As opposed to the extrinsic self-determined motivation, I go to the weight room. I'm not really jonesing to lift weights. I'm not super into it, but I'm doing it because I want to, look a certain way. Again, and then really, I think to a certain extent, sometimes it just depends on the day. Some days you're really into it, some days you're not, and that's perfectly fine. Theory of planned behavior. According to this theory, the intention to perform a behavior is the primary determinant of the actual behavior. So it's really geared towards intention. The intentions reflect the individual's probability that he or she will exercise, but not always translate directly into behavior because of issues related to behavior control. So you want to do it, but it doesn't necessarily mean that you will do it. Attitudes are the degree to which an individual has a favorable or unfavorable evaluation of the behavior outcome. Subjective norms are about whether an individual believes important people in their life value the behavior, and perceived behavior control is the perceived ease or difficulty of engaging in a behavior. Just note with some of these that there is a level of overlap. If you get confused on it and you get a test question and you get the test question wrong, hopefully I make it clear enough that if you know the material, you're not getting the test questions wrong. But if you looked at it at a different way, just let me know and explain it to me. And if you understand the concept, then you might get the points for that question. Theory of planned behavior. This is just kind of shows it in more of an algorithm type of graph or table figure. Socio-ecological models, so interpersonal factors such as that includes the social environment, organizational factors, the physical environment, policy. So this is especially a big deal in public health. We're looking at the individual, we're looking at relationships, then we're looking at where they work or their school or their religious affiliation and those types of things. Then we're looking at physical environment. So this would be roads, safety, crime rates, community design, and then policy. How do we engage in those types of things at a government level and at a planning level to encourage people to be physically active? So if we don't have the Riverwalk, then which would be more of a physical environment and policy, it was policy when it was built. Now it's more of a physical environment. I guess it's policy from a maintenance, maintaining those opportunities. But those are the types of things that if you don't have the Riverwalk, then people would be less active. People are active. I'm active. I like to use the Riverwalk because I think it's pretty. It has a level of calming effect on me. Helps reduce stress. All those types of things. But if it wasn't there, I wouldn't use it. So that's where the physical environment and policy come into play. So strategies to increase physical activity, goal setting. This is an important role for you as an exercise physiologist. It's a powerful tool for behavior change that cuts across numerous theories, but must be done as part of an ongoing process to be effective. Set both short and long-term goals. Individuals often focus on long-term goals. However, when attempting a new behavior, setting achievable short-term goals is important for increasing self-efficacy. This is kind of the video game theory. You start the early levels and make them easy so that the individual develops a level of confidence and improves, and then the levels become harder and harder. If you started with the hard level, people would quit because you kind of take a stair-step approach and you start easy. You develop a level of confidence where you get more engaged with the behavior. We need those types of things for physical activity and exercise. We want to make sure that it doesn't start out too aggressive. And this is an issue where you have individuals that are trained, are physically fit, that are exercise physiologists and personal trainers. They work, especially the personal trainers, they work with an individual that's a novice and they start too aggressive, and that individual is sore and sick and in discomfort and will more likely quit as opposed to starting at a more gradual level. The issue there is, let's make some short-term goals that are reasonable, that they can achieve and get that level of success. We have the good old SMART goals associated with goal setting. So be specific. The goals should be precise. This is something within your exercise prescription case studies that you really need to watch out for. The goals should be specific. So if you have a goal that says, I want to be more fit, that's not specific. It's hard to measure, so which is the next bullet point. The goal should be quantifiable. With these two, you need to have things like, I want to run the mile in 7 minutes. I want to run the mile in 10 minutes, whatever. I want to lift. I want my bench press to go from, or it doesn't even have to go from, I want my bench press to be 135 pounds. Whatever it is, it provides you with something that's specific and measurable so that we can determine, have you met this goal or not? Saying I want to get stronger, it's difficult to measure. So keep that in mind. Action-oriented goals should indicate what needs to be done. Realistic goals should be achievable. So if your current bench press is 125 pounds, to say that you want to work up to 135 pounds is fairly realistic and reasonable. If your bench press is 135 pounds and you say I want to bench press 300 pounds, not so realistic. So kind of keep that in mind. And I look at the goals that you establish, and sometimes I will tweak them to address these SMART goals, as well as I've seen goals that, just based on my experience, they're just not realistic. They're an individual sedentary, and then they want to run a 6-minute mile. A 6-minute mile is stout. That's not easy to achieve. So I don't want the person to have that as a goal. I'd rather have a goal of being able to run a mile at a moderate pace, something like 4.5 miles an hour, and be able to do it without stopping. Those are measurable. They could very well be realistic and achievable, and that's what I would want to shoot for. If they keep progressing over time, maybe they eventually get to a 6-minute mile, but that's not what I'm going to state as a goal early on. Timely, they should have a specific and realistic time frame. So something that you can achieve within 6 to 12 weeks is a good place to start. So you're looking at basically 3 months. Can you achieve this goal in 3 months? I think that's reasonable to state that. And if you achieve it quicker, then you can adjust the goal and make it more aggressive from there. And self-determined to me is a little bit of a mixed bag. Goals should be developed primarily by the patient client. I think it's okay to have goals that you as an exercise physiologist develop for the individual and working with the individual. And then the individual should definitely have some self-determined goals. But I think it's all okay for you as the exercise physiologist to have some goals as well. It's just that it should not only be your goals. Strategies, and to go back to the exercise physiologist developed goals, they should be reasonable, and they should follow an agenda to improve health rather than anything else. So you as an exercise physiologist might think, well, I want to increase this person's range of motion. They're very stiff, and that's going to improve health. And the individual doesn't really have a flexibility goal. They don't really care about flexibility. So in that case, you as the EP may develop that goal, but it's to improve health and it's reasonable and realistic. That's where I say the EP exercise physiologist can develop some of those goals, as well as working with the individual for what they want to accomplish as well. So strategies and approaches for increasing physical activity in general, enhancing self-efficacy, self-monitoring, goal setting, implementation of your intentions, reinforcement, positive reinforcement, social support, problem solving, affect regulation, completing activities that you enjoy. So we want to develop a well-rounded program that works on many levels. Counseling, brief counseling, and motivational interviewing. So obviously we're not counseling as far as psychological counseling, but counseling and providing advice would also be considered part of the definition of counseling. During the initial phase, the primary goal is to help resolve ambivalence and increase motivation for change. Change talk refers to an individual's mention or discussion of a desire or reason to change, making it more likely that change will occur. Some of the client-centered physical activity counseling, the 5 A's. So you assess the individual, you advise the individual, you agree, so collaboratively work with the individual, you assist the individual, and you arrange. You develop a specific plan for follow-up, feedback, assessment, and support. So we're working to help this person, and I think that's philosophically the key here is to think of this and say, okay, how am I going to help this person? How am I going to make this person more healthy? How am I going to help this person reach their goals? And it's not about me as the exercise physiologist. It's about that individual. And helping that person as much as you possibly can. So comparison of motivational interviewing versus advice giving. This is different, so it's kind of giving you the soft skills and, for lack of a better word, tact when you're working with individuals. Yelling at an individual, you'll see personal trainers do that. You'll see people doing that in the military with basic training. Those types of things, they may work on the short term, but the long-term success is rather limited. So we want to have the individual kind of take ownership of the exercise program. So counseling aim, explore why the individual isn't sure or isn't sure he or she wants to exercise and builds his or her motivation to want change, versus advice giving, persuade the individual that he or she needs to change and start exercising by providing an exercise prescription. So, these are subtle things, but it's all about the perception and the way that you address people. For the client, help the individual explore why he or she is inactive, how and why he or she might begin exercising, and how exercising is consistent with personal values. Use empathy. Versus advice giving is explain that someone who is inactive may be at increased risk for disease. So we do this a lot. I do it a lot. I give a lot of advice, and you really have to kind of think to say, okay, well, how do I go from giving advice to more of a motivational interviewing approach? And it's not going to be perfect. Sometimes you will give advice, and that's just the way it is. We cannot expect you as the EP to necessarily be perfect either in trying to do this. And maybe sometimes advice and hard facts are necessary as well. Information presentation, neutrally explain discrepancies between current activity level and recommended levels and allow the client to react. Give versus advice, giving the evidence for why being inactive increases your risk of disease. Questioning approach, open-ended questions to encourage exploration of thought and feelings regarding physical activity versus advice. Leading questions to have them prove to themselves the risks of their inactivity and why they should be active. Dealing with resistance, the motivational interviewing, use reflection to try to acknowledge their point. Resistance is a sign that a new approach is needed. Acknowledge that ambivalence to change is normal. Versus advice giving, have counter arguments ready and correct any misconceptions. And motivational interviewing, summarizing, use their language to summarize both the pros and cons of exercising. Versus advice giving, summarize the dangers of staying inactive and steps they should take to be active. So, as I said, I think we all engage in advice giving, and maybe to a certain extent that can be appropriate. But there should be a level of this motivational interviewing that allows for a kind of self-reflection and for the person to reach the conclusion that, hey, this is the better way to go. Methods to evoke change talk. Ask evocative questions. Ask the individual questions regarding to disadvantages, advantages, optimism, intention. Use the importance ruler. Ask simple questions to assess how important physical activity is. You could read these. I think it's important to kind of go through these and kind of really think about these things to say, okay, what's working? What do I believe in? What works with my personality? What should I do? Definitely this is an approach, and it should be something you consider and then go from. Strategies, approaches for increasing physical activity as a group leader interaction. 5 principles that have been successful to improve cohesion and lower dropout rates among exercise groups. So this would be more like corporate wellness centers where you're going to have a cohort of individuals that are becoming active as opposed to a specific exercise class and keeping people engaged in an exercise class. So distinctiveness, create a group identity. Positions, give members of the class responsibility and roles for their group. Group norms, adopt common goals for the group to achieve. sacrifice. Individuals in the group may have to give up something for the greater good of the group. So you might not do it for yourself, but you're doing it for the good of the group. And this would be like this extrinsic motivation. Interaction and communication, the belief that the more social interactions that are made possible for the group, the greater the cohesion. So as I mentioned, this is more associated with corporate wellness and things like that than necessarily an exercise class. Cultural diversity. This is something that should always be addressed and considered. In order to provide culturally competent care, it's necessary to be exposed to and understand cultural beliefs, values, practices of the desired population. And they are, that's easier said than done. And it's a matter of sitting back and listening to other people and realizing that you don't know everything. I think we're very much limited by our scope of experiences. And those experiences are real to us, and they guide the way we do things. However, once you realize the factors going on with somebody else, it helps you to develop a little bit more empathy. And hopefully the idea would be to develop solutions. Kind of goes with motivational interviewing. We're not telling people, hey, this is what you're supposed to do. We're listening to them, and based on the parameters of their life experience, we can hopefully work together with the individual to develop some solutions that help them and kind of take it from there. Perhaps the most important characteristic of exercise interventions that target different groups is to be culturally sensitive and tailored. Make sure I say that right. So we want to help people and work with what's going on for that group. So that may mean the way people dress. That may mean developing activities that group or that culture may enjoy. And talking to those individuals will help figure that out. I don't want to work off a stereotype and say, hey, this is a group of Hispanic individuals, so they're going to do a soccer program because Hispanics like soccer. That may or may not be true. I should go and talk to that Hispanic group of people and see what do they want to do. And maybe it is soccer. Maybe it's something else. So you don't want to create those generalizations ahead of time. You want to have that group work with you to figure out, okay, what's appropriate for that group of people. I will mention here, I don't know where I should have mentioned it, but with social support, to kind of keep in mind with social support that sometimes social support can help you and sometimes social support can hurt you. So kind of keep in mind that social support, family members, friends, it's often stated as a very helpful tool to engage in regular physical activity. But I also have found that other individuals, family members, friends, they can also sabotage your attempts to be physically active. They make fun of you. This has happened to me quite a bit. They make fun of you for being active. Why are you doing that? You're going to hurt yourself. Oh, you're just trying to show off. Those types of things. And when people see other people being successful, when somebody sees an individual engage in regular physical activity and a healthy diet, and they lose weight, and they look better, and they feel better, somehow they're not happy. Instead of being happy for that individual, they kind of take it as a judgment on them that, geez, this other person was able to achieve this, and I wasn't. If I bring that person down, then we're on more of an equal playing field. It's not ideal, but it is the way people are. And definitely quite a few people are this way. So just keep that in mind with social support, that sometimes social support can be helpful. If they're helpful, that's great. But sometimes they're not necessarily helpful, and to kind of keep that in the back of your mind. Finally, last slide, special populations. Various groups listed in the text: older adults, individuals with mental illness, the youth, individuals that are carrying extra weight, so the obese, people with chronic disease and conditions. So these different areas, they can need different targeted approaches. But I would say, everybody could be considered to be special for one, as well as things probably need to be individualized for everybody to a certain extent. You could probably group certain characteristics together, and that may very well be appropriate. But working with the specific parameters of the individual is going to be important. So kind of keep that in mind, and we'll address some of this in future sections, as well as in the future course of physical activity and chronic disease. Okay, that's it.